Hi, I'm Rachel Jantia, Geriatric Medicine faculty at McGovern Medical School, and this is the ICARE Geriatrics module, the 4 M's of age-friendly health systems, with a focus on medication. Our objectives are to define polypharmacy, to recognize potentially inappropriate medications in older adults, and to empower older clients to be knowledgeable about their medication and to communicate their concerns with their healthcare providers, including potential risk, benefits, and side effects of their medication. Older adults are prescribed a disproportionate amount of medications compared to younger adults and will make up 25% of the population by 2040, but will consume 50% of the prescription medications. Polypharmacy is on the rise in older adults. This is defined as taking more than or equal to 5 medications as a result of a number of different factors. The more chronic conditions you have, the more likely you are to be prescribed new medications. There is an increasing number of medications available to treat different conditions, including those that are prescription and over the counter, an increase in number of herbals and alternative therapies that older adults are using as a result of things like advertisements on TV and on the internet. Every time you have a hospital or emergency room visit, you have an increased risk of having a new prescription given to you. And then the more number of providers that you have, the higher the risk that you're going to be prescribed even more medications, and that there may be complications from that. Polypharmacy is associated with adverse drug events and drug interactions, as well as prescription cascades, and we'll talk about these in just a moment. But adverse drug events you have an increased risk of adverse drug events. The more number of drugs that you take, the more of those drugs that are inappropriate or potentially inappropriate, or at a potentially inappropriate dose. And then finally, inappropriate combinations of drugs, given an older adult's particular physiology and risk. So adverse drug events cause more than 1 million emergency departments and 280,000 hospitalizations annually. Approximately 1/3 of older adults experience an adverse reaction to a medication in a given year. And the risk of adverse drug events in older adults increases with the number of prescribed medications. If you only take 2 medications, 6%, 5 medications, 50%. And if you take 8 or more medications, you have basically 100% chance of having an adverse drug event. Let's look at some examples of what those might look like. If the initial condition is arthritis and you are prescribed an NSAID or anti-inflammatory medication for this, you increase the risk of something called acute kidney injury as a result of that medication. Another example, if you have high blood pressure and you're prescribed a diuretic, such as a thiazide, to treat this high blood pressure, adverse drug events include dizziness and falls, and any hospitalizations and complications that come from that fall. If you have insomnia and are prescribed a sedative or hypnotic for that insomnia, you might experience the adverse drug event of cognitive impairment or delirium. And this is a short list of many, 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 many potentially more adverse drug events. Prescription cascades are when a person is prescribed a new medication for a current symptom, and that new medication then causes a new symptom, and it has failed to be recognized as a side effect of that medication, is considered a new symptom and given a new medication, and you end up having a snowball effect of new prescriptions. So here are some additional examples. Let's say you have arthritis and you're again prescribed an anti-inflammatory NSAID. The new symptom that you get is increased blood pressure, which is a side effect of this particular medication class. Well, when you have high blood pressure, what do your healthcare providers tend to want to do? Prescribe a new blood pressure medication med. Instead, we want to go back and recognize that the high blood pressure might be a side effect of the NSAID. Let's take hypertension. This time you're prescribed a calcium channel blocker for that high blood pressure. Common side effect of calcium channel blockers, constipation and leg edema. You might be prescribed then in turn a laxative and a diuretic. Instead, we should go back and consider whether we should switch to a different high blood pressure medication that does not have these side effects. Last example, hyperlipidemia, high cholesterol. Let's say the person this time goes over the counter and says, I want to improve my health, so I'm going to start taking fish oil. That has a known side effect of indigestion. And then you present with indigestion to your healthcare provider and are prescribed a proton pump inhibitor. Instead, we need to go back, make sure we have a comprehensive med list that includes over-the-counter medications, and recognize the indigestion might be a side effect of the fish oil. And then we can avoid prescription cascades. So what are some examples of high-risk medications or potentially inappropriate medications in older adults? I want to point out the American Geriatric Society Beers criteria, which you have access to in your resources. This is a list of potentially inappropriate medications for the various different reasons, and that should prompt a provider to review whether that medication's benefits outweigh the risks for a particular individual older adult. Examples include diabetes medications because they increase the risk for hypoglycemia, benzodiazepines that increase the risk of falls and impaired cognition, antipsychotics that carry a black box warning for death and are associated with an increased risk of pneumonia and stroke. First generation antihistamines, which impair cognition, can cause urinary retention and falls. Notable examples of these are diphenhydramine, which is available over the counter for allergies, and almost any over-the-counter medication that includes PM in the name likely includes an antihistamine or other sedating medication. Vasodilators used for blood pressure can cause lightheadedness, dizziness, and high blood pressure, hypotension. Opioids can cause confusion, delirium, and constipation, and may be appropriate in particular settings, but we want to be aware of the side effects. Certain antimicrobials can cause things like joint pain and electrolyte abnormalities. Diuretics can cause orthostatic hypotension, electrolyte abnormalities, and kidney injury. And as we talked about, NSAIDs can cause high blood pressure. They can also cause peptic ulcers, kidney injury, and they are contraindicated in coronary artery disease. So lots and lots of things to be mindful of. And again, we have some resources for both you and your clients to review to examine whether you might be taking medications that are high risk. So how do we empower our clients to advocate for appropriate prescribing? Well, first, every provider should be thinking about the following thing at every healthcare appointment. They should have a complete medication list. This means our clients should be encouraged to bring a complete medication list that includes all prescription, over-the-counter, supplement, and herbal meds. They should be sharing information about medication non-adherence, and every single medication on that list should be reviewed for its appropriateness. A medication that was prescribed 10 or 15 years ago may no longer be appropriate due to changes in adult physiology as we age and our ability to process medication. We should also encourage clients to have an open discussion about with their healthcare provider regarding discontinuing potentially unnecessary or ineffective medications. Maybe something was started for a particular purpose, but never actually helped, and they're only actually seeing the risk of harm. Reducing medication doses, considering whether current symptoms could be an adverse drug event of a medication, and avoiding prescription cascades, substituting for safer alternatives, and considering non-pharmacologic approaches.